Just going to do some quick introductions. My name is Matt Stahl. I'm the Clinical Marketing and Brand Director at EloQuest Healthcare. We are the exclusive partners with Interrad, the manufacturer of SecurAcath here in the United States. And for those folks that are visiting us from outside the United States, I can always defer you to Laura Crick, who is the COO at Interrad. Many of you may recognize her, and also joined by her partner in the background, Jeff Killian from Interrad, and then of course the main draw for today's education opportunity is Cheri Gillette. Cheri is a vascular access specialist from the University of Rochester Golisano Children's Hospital. She has many years of vascular access experience under her belt, and she started using SecurAcath on the pediatric and neonatal population back in 2017. So has a lot of great experience. So this is an open forum where we welcome you guys to just throw questions out. And we will have our resident expert here to address those, and then also share some good examples of best practices, techniques, etc. So please go ahead, place your questions in the chat room, but also please don't hesitate to speak up. Turn your camera on if you'd like, and fire away.
So I'd like to take this opportunity. I'm really excited about sharing my experiences and helping other practitioners feel comfortable using this product. We have had phenomenal outcomes using this product, especially down to even some of our neonatal patients. So please, I'm really excited to share what I have learned, but would also like to help you guys in your practice in using a product.
So Cheri, while we're waiting for folks to type in questions or ask questions, I'll ask you a question. What would you say is the best method for removing SecurAcath? And I might ask you that question again later, but I'm going to start with that.
All right. So I would love to be able to demonstrate it in what we have found to be the easiest way for us and our pediatric patients. So we have our model of our SecurAcath right here. And what we do is actually the two finger hold, the first finger in your thumb, and pop off the top. Once we remove the top, we actually pull our catheter out first. So I'm just going to hold this up as the catheter is out of the patient. I use my thumb to hold the SecurAcath vertically. Pinch it together and have my index finger right over the blue part of the SecurAcath, and with a quick wrist motion, pop it. And you have to be able to pop with purpose. We have found that has worked the best for the patients. I do ask the patient what they have felt afterwards. Many times our pediatric patients have responded that they don't feel any discomfort. Other patients have said they might have felt a little pinch or a slight burn, but it lasts so briefly that they don't, they're able to recover very quickly. The other method to remove it, which I'm old fashioned, I went to nursing school in the 80s, and the one thing that was always purposefully stated was you never take scissors near a central line. So you got to remember, I work with the pediatric population. You would also have these considerations with a patient, an adult patient who has some delirium or is confused, has some dementia. You really don't want to take a pair of scissors near them for the risk of patient injury.
Yeah, that's a good reminder, Cheri. Thank you. We do feature on the website in our IFU instructions for cutting it down the middle and doing a removal, but appreciate that perspective. It may not be necessary to use that tactic. Cheri, I've got a question for you. Is there anything that can be done while the SecurAcath is dwelling with that line that maybe during care and maintenance stages, right? We got to we're checking on that at least every 7 days anyways. Is there anything that can be done at that point to impact removal?
So the one thing with dressing changes, I'm gonna replace this so I can demonstrate better. The one thing that we have learned over the last few years is when we have insertion, we actually want that the SecurAcath will actually sit up. I'm gonna turn, I'm gonna adjust things here. You want to have that little bit of an angle. Okay, I don't think this is picturing it very well. But the one thing that we did learn is in order to remove it with the least amount of discomfort that a patient can experience is actually training our bedside nurses on the appropriate way to change a dressing and cleaning. And the one thing we emphasize is moving this vertically so that you can get 360 degrees all the way around and set it back down. You don't want that twisting and turning. That twisting and turning will just cause discomfort, but by moving it up and down, straight up and down, it actually releases and from the scar tissue that can build up that will allow easier removal. If we've had a catheter that's been in for, let's say one of our HEMOC patients, that catheter has been in for 30 days, we occasionally will use like a little ice pack over the insertion site or a warm or a cool cloth, a sterile 2x2 with some sterile saline on it to help loosen up some of that tissue.
Good. I appreciate you sharing those techniques. You know, oftentimes that's where we get a lot of questions is how to do the removal and the concerns about. Is it fair to say that you see just like different levels, whether it's scar tissue or granulation tissue or a combination, is that pretty patient dependent?
It is very patient dependent. Like I said, most of our kids, if our average line stays in for about 65 days when we look at our cardiac population. So those catheters are in for quite a bit of time. We do use these on our 2.6 catheters. That's our longest, our most used line. And those are our cardiac patients with the long dwell times. And we have not experienced any real difficulty in removal.
Good. And those 2.6 lines you're using what French SecurAcath?
A 3 French SecurAcath.
Okay.
So one of the advantages of using SecurAcath is preventing that pistoning in using an adhesive securement device. And that because that pistoning allows that catheter to be exposed to the skin and reinserted into that insertion site, which increases your risk for infection. And Matt has a great video showing that pistoning.
Yes, I do. And I will show that here in just 1 second. Let me just share my screen. It's about a 1-minute video.
And evening with this pistoning of these catheters with the adhesive, I can honestly say we have decreased our migration. Historically, when bedside nurses have changed PICC dressings, no matter what age group, the biggest fear was pulling that line out a little bit. And as you know, as practitioners, the smaller your patient, the shorter the SVC. So you really risk moving that line. So it's no longer in an optimal position. Since you've been using the SecurAcath, we have not had that issue. If we've had any migration, it's been mostly due to natural growth of the patient. So if we use it on a baby who is 36 weeks and is in the cardiac care unit for 3 months, there's a lot of natural growth that happens. And that's where the only time we've seen the migration. We have not seen anything inadvertently with a dressing change. Our nurses love this device. They are no longer afraid to change a dressing. So these dressings are being changed more efficiently in a better time frame to prevent infection. Our HEMOC unit is another high use area, and they went almost 7 years without a CLABSI. We did have one CLABSI over 350 days ago, but we went for a significant amount of time. We have had so much success with this. Our IR physicians are actually placing it now on our tunnel lines. And intermittently, our peds surgeons are also placing them.
That's great. I'm already getting a request for the video. So yes, I'm going to put a link in the chat for that. And so that'll just take me a minute or two because I'm a terrible multitasker.
Matt, don't worry. I know Daniela. Daniela, nice to see you. Thanks for joining. I will make sure she gets a copy of it.
Great.
Yeah, that is a great teaching tool in enforcing why these securement devices are so important and so beneficial.
We had a very passionate practitioner capture that unfortunate circumstance for us and was very willing to share it because they knew they could make a difference.
Yeah. So Cheri, you mentioned that it seems like staff, not just engagement, but just, compliance, I guess is probably the better word, right? For those dressing changes to hit the standards. You say they love it, they feel more comfortable. What is it that makes them so much more comfortable about doing that dressing change, or what's happening during the dressing change?
Pull the line out. I mean, I've been doing this since 2007, and you'd be surprised, even back in those days, and not too long ago, since before we started using these, staff would not realize that once a line is pulled back out of the skin, it is considered contaminated. And our natural instinct was to push it back in to where it was. Yeah. So they're not afraid to do it. The time management for them, they're so overwhelmed with the acuity on the floor and the tasks that they need to complete for their patients that it only takes 5 minutes to change a dressing as opposed to 30 minutes. And in pediatrics, it's a 2-person procedure. Even in adults, when you have somebody who is confused, you do need 2 people or somebody who is not cooperative. So it ties up 2 staff members. Yeah.
It never happens at a convenient time though, does it?
No.
Yeah, I worked at the bedside in the ICU, and that was one of the things that I dreaded was, oh, it's my turn to do a CVC dressing change or a PICC dressing change. Did not want to be the person calling, the physician during midnight shift and saying, hey, we need a new line because that one popped out. Yeah, I wish we would have had this so I could do full 360 degrees cleaning. Yeah.
Yep. So for us type A personalities, that is a huge point of emphasis, is to be able to clean the whole surface area. I want to know that arm is clean.
And Matt, I do have some polls. I know we were going to wait a few more minutes until our scheduled start time, even though we started a little early and we have such great engagement from the audience. Maybe before we do that poll, we should just ask one more time, remind everybody you can unmute if you'd like to ask your question personally, share yourself on video. If you don't want to show yourself or you don't want to verbalize it, please feel free to post it in the chat. If you'd like to post your question anonymously, you can do that too by directing the question to Matt or myself, and we'll ask the question for you to Cheri. Again, Matt is with our EllaQuest Healthcare US partner. I'm with Interad Medical, and Cheri is our clinical user here in the United States with plenty of years of experience. I won't tell you how many because she only looks 15, but
I wish.
She definitely knows how to take care of our 15 and unders. And we've seen her do some amazing things with some very, very little ones. Cheri, what's the youngest patient you've ever had?
I think the youngest I've ever placed one at is probably about 33 weeks. And it was a lower extremity 2.6.
And so you routinely use the SecurAcath on your 2.6 French?
As long as I have enough surface area in order to be able to make sure that I can adhere a very good dressing and protect my line and device.
I think you shared a picture of that with me. Can I show that
Yes.
picture? All right, this is a great picture. Let me see if I can share my screen successfully. Share screen button. There we go. And I want to show that picture. And here it comes. So do you want to talk us through it?
So this is, I think this kid was about 18 months. It's an upper extremity. And as you can see, we do need to have enough surface area. I purposefully left 6 centimeters external because you do have to have 2.5 to 3 centimeters in order to use the SecurAcath. But this allowed me to have that nice gentle loop to prevent any catheter from kinking. It also allowed good securement to make sure that I had the site, my biopatch, my securement device, and my suture wing all secured very well under a single dressing.
And that's, I'm just highlighting. I'm hoping that the coloring is showing up, but you have the wings.
It is.
And this is under the border of the dressing. And those are really important.
And
really important to maintain.
You were obviously intentional on the looping to have a nice round loop and avoid any kinking there.
Yes, and even with the dressing change, so with the next dressing change, in order to, again, it's really important, especially in our young kids, our cardiac care kids who are edematous, cachetic, that we need to make sure that we have no skin injury. That's why it's so important in changing that dressing is lifting that SecurAcath vertically so that you can see underneath the skin. Knock on wood, we have not had any pressure injuries associated with using a SecurAcath. The biopatch is great because by putting it around the catheter and underneath the top of the SecurAcath allows that SecurAcath to sit in an appropriate position to keep the feet actually in the subcutaneous tissue and preventing torque on it to come up under the skin.
That's resting right here underneath.
Would you expect to get the same benefit if it was a brand other than the biopatch, like if it was one of those silver discs as opposed to a CHG disc?
Same benefit.
Good. You made mention something that I know I utilize in teaching a lot is your technique with the dressing, right? To avoid any pressure, the device causing any unnecessary pressure, undue pressure on the patient's skin. How do you describe? How do you approach that?
So when we're teaching on putting our dressing, I actually have one here, so I'm going to demonstrate. Let me.
Yeah.
So what we teach is to hover, just float and set it down, and actually do the outside edges. So it's almost a little tented because, but even if we just tent it a little bit, over time, this naturally goes into lays on the skin to give it the secure. But this is what you really want, is you want to make sure this outside edges are very secure. This is protected under the skin. The SecurAcath should be straight up and down, okay, not torqued or turned. A lot of our staff are so used to stretching their dressing and putting it down. What happens is that when it contracts, it actually torques onto the device itself. And that's when a patient may complain of discomfort. So it's just a matter of being able just changing the dressing, float and set, and then secure the outside edges. And it's naturally going to adhere to the skin.
Cheri, can you share that one more time? Just because I now spotlighted the video. I want to make sure that it's in focus for everyone.
Okay, so I'm gonna try to take this off.
Sorry.
That's
And
okay.
while you're taking that off, Cheri, I'm sure you're about to go into this next step, but we also want to make sure that the wings or the hub is completely underneath the dressing.
Completely under the dressing.
Yeah, if you're putting like the pants or the belt on, maybe you can't get it under the initial dressing, but it needs to be under there, and that really helps with securement.
Well, it doesn't help just with securement. It helps with any type of fracture, twisting, and turning on that line.
Mm-hmm.
And that's a big piece of it because you don't want to have to replace your line. So if you have that extra piece hanging out and a patient's getting up out of bed and walking, it's going to twist and turn. And these lines, even if they're made of polyurethane, they can kink. And over time and kinking, it breaks down the material, no different than any silicone catheter. And you go to flush it and it breaks. Or the patient catches their IV tubing in the bed rail as they're going to get out of bed and it could snap. So it's an overall protection, not just for infection, but also for line securement to prevent that line from fracturing. So you ready?
Yep.
All right, so it's a matter of floating and then setting it down. You're dressing over the top, securing your outside edges. And then as Matt just described, it's really important to put the pants or whatever dressing you're using to put the securement on underneath to prevent that torque on your line. And because you don't want that twisting and turning.
And I have one here. I'm going to spotlight myself for a minute and try to switch that. So, oh, thank you. This is a drain catheter, which doesn't have those securement wings on it. And our instructions very clearly state that we want to see at least 2 centimeters distal from the end of the SecurAcath of the catheter when wings are not included. So when there are wings, the reason we emphasize that the wings are underneath is because, as you indicated, in smaller catheters, the wings are sometimes several centimeters. So we don't want to specify the centimeters. We want to be specific to the wings because the wings are the weight, and the weight is going to transfer any tension to the catheter body where the SecurAcath is holding. So we don't want that tension to transfer to the catheter body. On these larger catheters or drainage style catheters that don't have wings, the transfer is right to that spacing. We found that at least 2 centimeters reduces that tension at the point where the securement and the catheter meet, which reduces the chances of the catheter stretching. Now, it doesn't prevent that from happening 100%, because if the dressing becomes somehow lifted or not intact, that again puts the tension right back to that point. But what we want to do is alleviate tension right here. Again, as rare as it is, that is one of the things we try to prevent. Why we're instructing any type of catheter slippage happens because this catheter is getting too much tension and it stretches the catheter below its exerted forces, its maximum forces. So again, the wings are important on catheters with wings, and 2 centimeters minimum of catheter under the dressing for catheters that don't have wings. So that's a technical manufacturer's explanation. How are we doing with questions? Anybody posting?
Not yet,
right.
But I just put something in the chat. Again, guys, just want to encourage you, put your questions in the chat and then we can just answer it. Or if you're feeling brave and you want to talk to Cheri directly, please feel free, just take yourself off mute and speak up. We'd love to address your questions. That's what we're here for. We will also sprinkle in some best practices and some anecdotes along the way. See, we have some guests continuing to pop in or out.
And I do have polling questions ready when you're ready.
Yeah, well, we're at the top of the hour, so why don't we go ahead and fire the first one off?
All right, I'm going to launch this. Cheri, you want to give it a read? Is it on your screen?
Yep.
Right.
I see SecurAcath. All the time, sometimes, rarely, or never.
Feel free to select your options. I will share the poll with the group. There's a second question on there. Now I see there's about 18 of you in the group. I'd love for you to answer. Please feel free to comment regardless of your role. We want to know who you are, who's joined us today.
It'll be anonymous.
I've only seen 5 people answer. Come on, guys. If you don't see the poll, let me know in the chat. So maybe I did something wrong, but it looks like it's showing up for somebody. There's 7. Woohoo! Come on.
Guys.
Give me a quorum.
Double digits is in our
Double
reach.
digits
Let's
is
go.
my goal. Yeah.
Cheri, do you want to kick out the second question there as well?
Sure.
Uh-huh.
As soon as I see it.
Just gotta scroll down a little bit.
I was gonna say widen the window if you can.
Yeah.
You might not be able to. I'll read it for you.
You
It
can
says
scroll down.
Yeah, because I don't see it.
in the window, it should allow you to scroll down. SecurAcath improves. Select all the following that you agree with: dressing care process, premature catheter replacements, risk of infection, confidence of care providers, patient care. Probably has other things, but I thought those were really what you were saying when you were talking, Cheri. So
Yes, yeah, absolutely. And I think what we all need to realize is the efficiency and saves on nursing time.
all right, it looks like we've achieved double digits. Our folks are
Yay.
maybe too shy to answer. Oh, 11. I'll give you one more second here. I'm gonna end the poll and share the results so everybody can see them. Hopefully they pop up.
Awesome.
All right. 3, 2, 1. And I'm going to mute my visitors here. Oh, they got it. They opened the door. All right. There is another poll. If we want to go.
That's incredible. That's incredible. That's awesome.
I'm
Hey
glad.
guys, we got a question here.
Good job.
And this is from Daniela. When we use ice, we should put direct on top of the dressing. For how much time, question mark, do you have some tips to share with us for this? So I know you touched on this a little bit, but if you could revisit that, Cheri.
So it depends on how much cold the patient can tolerate. So for most of our kids, when we've had to use it, we have put cold soak on for probably 2 to 3 minutes. We have, like I said, we haven't had many issues with removal with quite a few of our patients. So we've only, I think, I know it personally, I've only had to use a cold compress only maybe twice that I can remember in all the time we've been using it. I can be honest with you and tell you the first couple of times I did remove one, I was a little nervous. But once you get the hang of the with your fingers and realizing you really have to take it out with purpose and not hesitate. It's the hesitation that's going to cause discomfort.
I was going to ask you, why do you think you don't see as many issues? Is it because you have a select group of folks that are trained to do removals? Or is
yes, so our team currently is the team that removed 99% of them. We have had a couple of physicians in our outpatient clinics that have removed them by pulling up the website and watching the removal videos from SecurAcath. We are the ones that have removed 99% of them. We have trained and had a couple of the nurse practitioners, but they haven't had the repetition to develop that comfort level.
And I think that's really what we see with the hotline. I answer the hotline here. And what I notice is that most of the folks that are struggling or get to the point where they're calling for help are folks that have never done it before, or never had formal training, or received the training a long time before they're actually needing to apply it. And I think that goes for anything we do, is that it's important to know, to have the training immediately followed by the practice of the skill, whatever that skill is. And this is not something we're removing every day. So unlike other securements that you remove with every dressing change, we keep this on for the duration of the catheter. And it's really important to remember that, and to help folks that aren't removing it every day, how to keep those skill sets strong. Having practice pad simulation training tools like these available to them, and also using the videos and e-learning tools that are also available on our website. I think that's really important.
Yeah. Oh, we got to thank you. So looks like that was a satisfactory answer. Thank you for that. Yeah, and just a great reminder that we try our best to make these teaching and other resources so easily available. We try. I'm sure the intention was of putting the branding right on the device was, if you first time you see it, go and Google SecurAcath, take you to videos, take you to the website where there's a plethora of on-demand training tools available. I know I use them myself, and certainly recommend them. So thank you for that question. Please, guys, this is for you. This is for your questions. These are for those burning questions you've always had, but maybe we're too scared to ask, or never had the opportunity to speak to an expert with several years of SecurAcath experience, like Cheri Gillette, who's joining us today. I think we got another poll up, and I think it's a good time to jump into that, just so that we get to know the audience a little bit better. And then we can decide where we'll take the next round of discussion. So we would love to know, so 2 more questions here, what your current clinical work setting is, and the job title that most closely describes you and your responsibilities. So we'll give you guys a couple minutes here to fill that out, and we look forward to learning more about our audience.
Again, if you're not seeing the poll, it might have popped up on a separate window or behind the maximized window. The poll is now on the screen. Please do click and answer. It helps us. Danielle, I want to go back to on that ice question. So, Cheri mentioned cold compress. I think this can be done depending on the clinical setting a couple of different ways. Some in a hospital setting, you can have chilled sterile saline syringes or chilled saline available, and use the sterile saline on some soaked gauze. So you're getting 2 for 1. You're soaking the insertion site with sterile saline gauze, or you can have it under the dressing. What I don't recommend is to do the cold compress or cooling strategy with the catheter still in place. So I usually recommend this, that you remove the lid, remove the catheter, then apply the cold compress. If you need to put a dressing on to have a barrier between the insertion site and that ice pack, depending on your clinical environment. So like in the home care environment, the ice is typically coming out of the patient's freezer, going in a Ziploc bag. So in that setting, I would ask the nurse to either put a sterile gauze or a dressing over it for a few minutes. But just a couple of minutes to numb the surface is all you're looking for. You just want to chill it enough that that swift, deliberate motion doesn't create any pain. It acts as a placebo effect in some ways, because they feel like you're addressing preemptively their concern for pain. But if you tell them, often if you just say, the worst this is going to feel is a pinch, and you know that your skill level is there, the distraction technique of asking them to cough or sneeze or take a deep breath, and making sure that you have it out within that time frame, that breath or that cough is really important. The cough is not adding value to the removal, but it is an accountability metric for you, the clinician, to remember to remove the device in a timely manner, swiftly, not with hesitation.
So one of the other devices that our service just got 2 of them is a buzzy, and using that buzzy above the site before you remove. And I'm going to be honest with you, I'm a needle phobic, and I used the buzzy this time for the first time for my flu shot and did not have a panic attack. So that is another easy thing that you can carry in your pocket when you have to go and remove one. It also acts as a form of distraction. So that's another, you know, if you're nervous about putting cold or something over that insertion site, that's another tool in the toolbox that we can use.
And that's also maybe that tactile counter traction can act as that sort of distraction technique too. You know, you put your emphasis, the touching on the other hand, so they're paying attention to the feeling from that versus what you're doing with the hand that's actually lifting the feet out, if you don't have buzzies available.
All right, well, our latest poll has been up for a little over 3 minutes, so I think we can wrap it up for this portion. So I'm going to end the poll here. I'm going to share these results. Okay.
I beat you to it. Sorry, Matt.
You did. There you go, Cheri. There's a little more info about our audience.
That's awesome.
So looks like everybody except for Taylor and Kiara. Hey guys, work primarily in the hospital and have some familiar job titles.
And last time, I think we had a lot of home infusion folks or home care folks. So nice to see diverse folks joining the call and asking questions. As a reminder, please feel free to post your questions. If you don't want your name associated with the question, you can post it directly to myself or to Matt if you're being shy. But feel free to post any questions that you have. Cheri's here to answer them. It's an open format. We're just going to keep the conversation going.
So for all those who have seen SecurAcath, have you been able to get your hands on them? I'm sure in reactions you can give me a thumbs up or a wave or whatever, but I'm interested to know how many people have actually had their hands on it.
Yeah, that's a great way to do it, Cheri. Just have them give a thumbs up if you've had your hands on SecurAcath with a patient. The reaction buttons in your menu on your Zoom screen. I see one thumbs up coming.
My second question, there's a thumbs up. My second question is, how many were afraid of it when you first saw it?
You can give the wow face. There's that's options though.
Because I know when I first saw it, I was thinking, oh boy, I'm not sure about this. You know, those feet gave me a little tummy ache when I first saw it. And it took me probably 5 or 6 of putting them in before I was like, oh, hey, wow, this actually is going to work really well. And I had no patient complaints. And let me tell you, those who are going to complain are usually the adolescent males.
No.
And we didn't get any complaints of discomfort. And I was actually kind of surprised. I'm not going to lie. And I thought that was a little more eye-opening for me.
And you have a diverse patient population where you are, right, Cheri?
Very diverse, and like from neonate right up until well, now we're getting adults from the adult cardiac continuing program because they're congenital hearts. So we get adults too.
And it's a large university hospital for those that don't know where you work.
Yep, we have 154 pediatric beds, and we're somewhere near 800 adult beds.
You know, I always like to hear the story of how you were first introduced to SecurAcath. What was it that really encouraged you to? Because I know you're involved with AVA and all those organizations, but what is it that really kind of gave you the confidence to take that next step? And I believe that was just a product evaluation, right?
Well, we did the product evaluation. I believe I first saw it at AVA teaching day, and I had been concerned about the number of exchanges we were having to do because of not malposition, but actually with accidental dislodgement, more from dressing changes than anything else. And we were starting to have to exchange a lot of lines, which we were teetering on that CLABSI rate kind of issue. And when we looked back, you know, it is a risk. And then we risk thrombus in our cardiac kids. So I was looking for something to give nursing more confidence in what they were doing, more comfortable, less time consuming, and saving our patients bad outcomes. And that's when we got the approval for the trial. But coming to the table with what our problem is, here's some alternatives on what I think is going to work, and then doing the cost analysis. And that's where SecurAcath, Interad Medical, when they brought the evaluation in and was able to articulate a financial benefit, we had no trouble bringing it in. And my team, we have a team of 5, we will never go back. In fact, we are praying someday there's something better to help secure those 1.9s.
No, you're not alone.
Hint, wink, wink. Yeah.
Yeah, wink, wink.
No, you're not alone with that feeling. I know we get that question a lot.
Yeah.
So Cheri, I know that we chatted about, preventing issues with SecurAcath and being very aware of that. Your team's very diligent at checking on your patients and rounding on your patients routinely. You had an issue the other day that was potentially a bad situation. I have a picture of it. Do you mind if I put it on the screen and share it?
Not at all.
Maybe you can share that story with everyone. All right. Here you go.
So this is a dressing when I worked on Saturday and rounded and found. And as you can see, those suture wings are way outside the dressing. I took this opportunity to have a great education learning moment with a newer staff nurse. And as you can see, the SecurAcath is at a cockeyed angle. And we went through, I was her second pair of hands, and we went through and did a dressing change, and actually found that you can see the tightness at the bottom of the SecurAcath where the line was actually kinked. So we went through the proper dressing change practice by our policy. And I talked about the SecurAcath and how to align it and what to look at and look for when you're doing your dressings. And the importance of having that whole line and suture wing underneath that dressing, because as you can see, the pants at the bottom of the dressing acts as that extra, I like to call it more of a seat belt, and to secure that under the dressing to prevent that torque on the line.
So with your audits, you were able to prevent this from being dislodged. The catheter was
Not only dislodged, but fractured
because of that kink. So you were
Yeah.
able to redress that and get it to look more like that first picture we shared earlier.
Yes.
And this, I think, is a great reminder of how important routine assessment is. And not everywhere I go do I see the vascular access team or the specialists taking accountability for the lines that they're putting in and going and looking at them at what the bedside nurses are doing. And I think in this post-pandemic environment that we're in, we can all acknowledge that there's a big shift in practice, a shift in awareness and standardization, and we're trying to get it back to what it was when we were optimized. And with the staffing changes, with the frequency of turnover, maybe some lack of experience on staff in some cases, it's really important to be checking, inspecting the routine work that's being done and protecting your lines. So not just putting them in, but making sure you're protecting them by looking at how are they being taken care of when you've turfed them out to the units for use.
And I'm sure a lot of the attendees on the call that are working in a hospital, they're all dealing with the same issues as we are, with short staffing and a lot of new experienced nurses, and orientation and trying to orient and trying to demonstrate best practice, that we get lost sometimes in what is actually happening to help our staff. Education is so important, and I think that's one of the things about using SecurAcath and using EloQuest. We have had nothing but the best support, especially in our learning phase, and the persistent follow-up that has kept us encouraged if we, run into an issue or whatever.
Yeah, thank you, Cheri. The support is there. The partnership between EloQuest and InterAD certainly brought more clinically trained support to every major metropolitan area. And the tools that Cheri described a little bit earlier about really helping to explain the cost benefit analysis around SecurAcath, which can very often be a daunting task, right? All that admin work, it's overwhelming. When am I going to have the time to do that? So we handle that administrative burden for you. And so those are that's just a little bit of insight into the resources and the support that EloQuest and InterAD do make available. Cheri, I think it would be great now if you could just take us through insertion, really the considerations, all the way through the actual placement of the SecurAcath on a line, and really those nuances that you do such a good job explaining and training around as it relates to the neonate and pediatric population. Give you a chance to break that down and
break mine down.
Yeah.
So the biggest thing for us is it really takes really thinking through your whole process when you're assessing your patient, where your insertion site's going to be. Upper extremity, we don't place many lines in the antecubital. There are or neonatal patients where that really is the best spot. You only have an arm that's 7 centimeters long, so you don't have a lot of leeway into how you're going to secure and how much line you're going to need out. The bigger kids, it's not such a big deal, but you do need to think about that process and the length of your SVC, and those, again, we have such a wide range of age groups in that patient. And then to determine how much you really want to have external. So if I am really high up in the arm, if I'm way up here in the arm, I know I have a good distance to be able to where I can have my SecurAcath sit appropriately and maintain a good dressing. Whereas if I'm sitting here lower on the arm, I don't want to put my SecurAcath down here to the bend of the arm. Okay, so I will pick my insertion site up a little bit higher. My team has learned 2 ways to put in their SecurAcath. One of the biggest things is we don't do much of a dermatometry. I can't even say that word. We don't do much of a nick, if we do a nick at all. The one trick that I have learned that has worked really well is to take my inner cannula of my dilator, put tension, hold my, I want to make sure you can see this. Hold my catheter with one finger, my middle finger, my naughty finger, and stretch my skin with the other 2 fingers. And in those kids that have that real doughy skin, I will actually come in from the side and get the base of one of those feet in and turn it, insert it a little bit further and let it go and bring it down, and then bring my catheter down. If we've had to do a nick, I have a hard time doing this sitting down. I'm too short. Too short. All right. And of course, I love my, huh?
It's like not the clinical setting where you can raise the bed to your working.
No, exactly. So I have my, can you see the teeth
Yes.
at the L-shaped? Okay. Is actually follow my catheter down, put it at a 45-degree angle to make sure that I'm in the subcutaneous tissue and not just underneath the skin. That's really important, not to have it. You don't really want to feel those teeth or see them right here right underneath the skin, because what's going to happen is over time, you could have the risk of this not being at the angle it needs to be. And these teeth, depending on if you have a very cachectic kid that's full of fluid, you risk that tooth or that foot coming up from the underneath the skin and poking through. So that's why it's so important that when you put it in, it feels funny and it looks weird, is to have that little bit of an angle on that SecurAcath. You want to see that little bit of angle. That means your teeth and your feet are buried in very securely into that subcutaneous tissue. I do the top and fold and put my both fingers underneath, and then always making sure that my catheter is in that channel so that I don't have a kink. But if you're
go
go ahead.
No, I was just going to ask the audience again to post any questions. We have a lot of participants here. I'm sure you're here because you have a question. Cheri has years of experience with SecurAcath now in a variety of patient populations. So it's, really great person to be asking your questions of. But yeah, that was an awesome demonstration of insertion. I think it's really important to come in on a side angle. I think a lot of times when I'm teaching, what I see most new users do is they drop the toes in straight down, but because of the curve in those anchors and the flexibility of the nitinol, they bounce on the dermis. So they just kind of compress the skin in and bounce back and compress the skin in, and then they're I think expecting that it's going to cut its way into the skin, but it's designed to not damage the skin. It's laser cut and polished. There's no cutting edges. And it's really, really important that sliding it in, like you slide an earring into your piercing, you have to slide it in where the hole's already got a path. So I think the way you demonstrated that was excellent.
The only issues we have experienced, in fact, we just experienced one this week, is in the outpatient setting. So we have a large Mennonite population, and the family is sometimes responsible for doing the care. We don't have a lot of pediatric experienced home care staff, especially in some of the rural areas, that she came in, but because her SecurAcath, one of the feet came up through the skin. But in looking at it, her SecurAcath had been torqued a lot during dressing changes. So that really is one of the first in 5 years, 6 years that we have seen that. But again, it was, a longer term patient who had been home with inexperience.
I think that's a good
in the
opportunity.
field.
Can you demonstrate the proper motion versus improper motion on your pad? So what is okay to do?
What do you mean?
When somebody's doing a dressing change, what is the appropriate lifting and movement? Because, some people say we're telling people to lift it, but we're also telling them not to over manipulate it. So what is good and then what is not good?
So the best practice is just to move it straight up and down. Straight up and down. Like this.
Yeah.
Like a door hinge. Like you're opening a door, straight up and down. No torquing this way or this way. You don't want to put your dressing on with like you saw in the one picture where it's off center. Okay. That is going to put torque on the feet underneath. So it's straight up and down like a hinge.
So whatever orientation it's deployed in is the same orientation we want to see it in after dressing changes.
So let's talk about that. So if if I need to come to the side, I am actually going to deploy it on the side. And then put my dressing on. Now that my dressing's all goofy. But put it this way. Okay. So, but generally, most of our kids, we have oriented it so it's straight up and down.
Yeah, what I've seen, and I try to put myself in the position of that person doing the care maintenance, right? Maybe not on the IV team, is during the dressing change, when I remove it, just look at where it wants to sit naturally, right? That will diminish any chance for any torquing and any pain or discomfort that'll be related to that. Just look at where it wants to naturally sit. And then I love that word, just float that dressing down so it stays in line there. That will also, right, prevent that lever action, right, of those feet coming back through the skin with a gentle floating of that dressing. So that step in that care maintenance phase is so important and directly related to patient comfort and better outcomes.
Right. And it's our natural instinct to want to change the position of something to give that skin a rest and prevent any type of pressure injury. So it's a natural instinct for us to do that, which is a culture change when you're using this device.
Yeah, it's important to educate on for sure.
Yeah.
Let me ask you another question, Cheri. What do you think from an inserter's point of view is the typical learning curve? So from when you look back at how long did it take you versus some of your colleagues to feel really comfortable using it routinely?
Right. So for people who are tactile and hands-on learners, like myself, it probably took me 5 or 6. Are there days where I still struggle to get one in? Absolutely. But you have to have patience, especially if you're not doing any type of nick. So it may take me 1 or 2 tries to get it off or get it in. I've had the feet cross and then had to take it out and then reinsert. So in precepting my coworkers, some got the hang of it quicker than others. And again, it's, the type of learner that you are and getting comfortable. It's those patients that have that doughy skin that's hard to keep stretched without an extra pair of hands kind of thing. It's no different when you have those veins that roll and you ask somebody to hold up above it so that you can hold below it and get a good hold. So I would say it easily takes 5 or 6 insertions to feel comfortable. And that is quick repetition. It's not do one week and then not put one in again another 2 or 3 weeks. You need to have that repetition one after the other. Yeah. It's the same thing with removal. The more you do, the more comfortable you are.
I'm going to share, you mentioned the feet crossing, and if you don't mind, I'm going to kind of comment on that. I'm clearly having camera issues, so I'm going to go back to this. But why that happens is the nitinol is tissue sensitive. It recognizes the pressure or the tension. And so the dermis and the subdermis are 2 different densities. So once it goes in, if it's in the dermis and you deploy it, the feet are crossing because it finds that pressure. You can observe this too. If you put too much tension on the line, you'll start to see those legs crossing. That tension is telling us that it's still in that dermal layer. Something that we've been discussing amongst longer term users, especially those that are doing it on PICC lines in the vascular access bedside setting where ultrasound is readily available, is to use your ultrasound to see that the feet are in the depth of tissue you want it to be in. So again, if you find that you're struggling to get the deployment or you don't trust that you've gotten it in deep enough, before you just remove it and then start over, what we would recommend is assess where you're at, pinch the feet together, and then push forward. Pulling it out makes you have to start the process all over again. If you're in, but you're just not deep enough, you just really need to pinch the wings together and hold the skin taut so that you can get past that layer. So versus being in this layer here, you just want to get a little bit further down when you deploy, so that when you pull back, you're just resting at that surface layer of the tissue. So I'll try to show that again with my pad here. Woo. But if the foamy part here represents the soft tissue, and that's the dermis, when we put the toes in and we deploy, if we're superficial, we're going to be sitting here at this level here. And so the feet will cross because this is thicker than this. When I am already there, what I want to do is just deploy my feet deeper into that tissue, then release, then retract, so that I'm sitting right where I want to be, which is right at that junction between those two tissues. So our ultrasound can show us those layers much more easily than we can guess. And tension is usually the variable, like you mentioned, doughy, and I know we offended Jeff, but that's really where I see it, is when the skin is either very, very loose. Like a lot of times you're not dealing with elderly patients, so your skin is young and very gelatiny. The folks I see often sometimes are very stretched out skin, very sun damaged skin, and you have to hold that skin very, very taut. It sometimes is stubborn when you're trying to get past it. So those are some things. The other thing I always teach folks to do is pay attention to what you're feeling when you're putting in your dilator over your guide wire, because those transitions of that initial dilator transition into the dermis is really a similar force and a similar pressure you'll have to apply to these feet, because they're blunt. They're not following a guide wire. They're following in the open hole you created. And that tension or that force you're having to put is really what you're going to have to put on the toes to get them past that dermis.
I think you've covered a huge chunk of them here, which has been great. I have been thinking the exact same thing. What can I ask? I'm like, wait a second, they've already been asked.
I'll ask a different one. I know that I get asked this all the time, Cheri. What do you do if a patient has a nickel allergy?
That's a good question. I haven't run across it.
So it's not that common an issue. That's clearly the case in several hundred or several thousand patients you've taken care of. But if you were to do it, what do you think you would do? If the patient had said, hey, I have a nickel allergy, is that okay to use? Would you still try to use it? Would you consider not using it?
No, I probably would still use it, but monitor that patient for any adverse reaction to it.
And that mirrors our recommendation, because the nickel in nitinol is treated in our device. It is laser cut and polished, so it's deionized. Nickel allergies typically are from costume jewelry, is clinically reported, or frequent contact with buttons or metal that are not treated in the same manner. And that is dermatological response. The allergies, as reported, are more of like an erythema or a redness at the contact point, but it has never been reported to our knowledge that there's been an anaphylactic reaction to nickel.
I saw Jasmina.
Yes.
Try to pop on.
I see Jasmina. Yeah.
Did you have a question?
She might have just unmuted for a second. Jasmina, do you
Maybe.
No, sorry.
Don't be sorry. We want to hear.
No, don't be sorry. I didn't want to think you were being ignored, though.
Please feel free to type your questions. I know some folks are from other places, so you might not feel comfortable posting or typing in English. Feel free to post in your native language, and I'll use the quick translate function and do our best to translate your question and get you an answer. Our goal here is to help everybody know better, talk better, feel better, and more confident about SecurAcath in their clinical practice and their clinical setting. We have seen it grow all over the world now that we're in 38 countries and continuing to grow. We have now over 25 peer-reviewed studies. This is something I'm proud of. I think Cheri's going to work on one. No pressure, Cheri. I'm calling it out publicly.
Yes, we are.
So yeah, I'm very excited. There's some other folks on this call. Maybe we can get interested. Clinical research is always something we'd like to see more of. Lots of opportunity there because, you know, really SecurAcath's publications have been mostly in long-term tunnel lines and PICC lines. And we'd love to see it in more of an acute application, midlines. We know people use it on those applications all the time. Acute central lines, drainage catheters. There's a lot of opportunity to prove the value to our patients. And the more it works for you, the more others need to know that that's happening, and publications are the best way to share. So that's my little plug. Frequently asked questions. I know we have a couple of folks. Taylor, I see, is on. Taylor, what's a question you get asked often? Maybe Cheri can answer it.
Sorry, I had to unmute, but great question. So a few that I get, you know, obviously some of them have been mentioned that, you know, initial response to it is it looks painful, but until you get your hands on it and get the experience, you know, it's just kind of that reaction. Another one I have is, I saw you had the BioPatch on there. I actually just got this yesterday. So does it work with BioPatch? Does it, are they compatible? That's one I
Yes, they are
get.
compatible. In fact, we really like the BioPatch because if you apply it, the BioPatch correctly with the line in the center little circle, and it sits under that SecurAcath, under the top of it, it helps keep those feet angled into the subcutaneous tissue.
Can you show that one more time, Cheri? I wasn't fast enough.
You weren't?
No.
Yeah, so if you open up your BioPatch and place it so that it's the slit is directly under the SecurAcath, it actually helps to keep that those teeth angled downwards into the subcutaneous tissue and keeps it from torquing up through and causing discomfort.
So that's the other question then. How do you prevent discomfort in general overall? I mean, obviously you're using the BioPatch, but the key point I think is understanding, especially in your littler patients, angles and where the angles are.
So that's where the dressing comes in, and just floating it and allow it just to sit over the top and set it down so that it prevents that torque onto the line.
What was
Did I answer your question, Taylor?
Yes, you did. Thank you.
Okay.
Appreciate it.
I'm going to play off of that question. What was the demonstration or moment? Because you said you too were hesitant initially. You thought it looked a little intimidating. Maybe you were scared that it would hurt your patients. Not to put words in your mouth, but what was it that got you to say, I think this is worth trying? I know you mentioned infection before, and
the risk of infection, but the aha moment for me was probably after that 5th or 6th insertion, where I felt I had a handle on the insertion piece of it. But it wasn't until we had a couple of patients on the floor, and one kiddo was a 16-year-old big boy, autistic patient that was at a high risk for dislodging his line. The staff were very hesitant in changing his dressing, and literally it took probably 3 people in order, 1 to keep him engaged, and actually 2 to hold his arm. It took more of us because we did use Child Life, but it took 3 of us, 2 to hold the arm and 1 to change the dressing. The efficiency, the decreased stress that patient had, that was like my aha moment that, man, this is really going to work, because that line did not come out.
fantastic. And I think too, like the context of knowing when a line does come out, the process, the pain, the delay of care, that going through a whole nother procedure. If you're talking about children, the anxiety, the procedural anxiety that you're compounding.
Their anxiety is over the dressing removal, not so much the line, but it's the dressing removal. And so they can articulate the dressing was worse than the SecurAcath coming out.
All right. That's great to hear. did we ever before SecurAcath worry about pain of securement?
No, because it was a sticker. And the sticker caused a lot more trauma to the skin and to the patient for removal than anything else. That was the most fearful thing for kids.
Mhm.
And when you think about your elderly with that fragile skin, you know, you look at those long-term patients on steroids, you look at, you know, that they have paper thin skin. We did so much damage to their tissues.
Mhm.
Yeah. And I think that's the idea here is we've tried to eliminate as much adhesive as we possibly can. We'll need a transparent dressing until somebody invents some other strategy for site protection. But at this point, you know, the eliminating having to replace the adhesive securement at every dressing change is really, really, I think, what we differentiate ourselves, because you're not having to change it. You're not having to interact with it. You're keeping that line stable through those dressing changes.
And the one patient population we haven't talked about yet is our burn population.
Ooh.
So when you're talking about our burns, you know, we get a lot of bathtub burns. We get a lot of scald burns from hot water, hot tea, hot coffee, boiling water. That affects all upper extremities. It affects lower extremities. You know, we have a burn trauma unit. And the old traditional of having to suture a line in because you can't use adhesive. You can't use an adhesive dressing. You may have just a 3x5 square or 3x4 square of free skin to be able to put a line in. The
Mhm.
SecurAcath has been phenomenal because we can't use adhesive. These kids are getting burn care every day where they're getting slathered with A&D ointment or, you know, bacitracin or whatever they're using. You can't maintain a dressing. So the SecurAcath has been a blessing for those kids. So yes, we're doing daily dressing changes because of the burns, but it allows a little bit more freedom and less damage to what good skin they have by using adhesive. And we're not using sutures. Because again, that's another break in the skin. And when you already have such an impaired, it's your first organ and you're already impaired from top to bottom, that it's adding insult to injury. So that has been a huge plus for us, is in that, especially in that population, because we can use gauze and Coban. And that's generally what we do, is the gauze and Coban, because they're getting those daily dressing changes.
Cheri, at your institution, how do you maintain staffing education? What tools do you have?
So the great question. So we do our let me start over. Our pediatric nurses shadow us, every single one outside the OR and outside the ED, shadow us for 4 hours. And we do one-on-one teach back method of we call them our pink bucket dressings. So we go over SecurAcath, we go over adhesive, in case a patient comes from another institution that doesn't have a SecurAcath and a dressing needs to change. We do go over using a adhesive securement. We teach our pediatric service orientation and go over central lines, dressings, the policy. We also go over peripheral IVs and extravasation. And then we do a lot of one-on-one real-time education. So if there's a dressing that needs to be changed, we ask the primary nurse who's taking care of that patient if they would like us to be their second pair of hands. So that, again, we can help in real time guide their practice.
Mm-hmm.
We have a lot of time investment in education.
And your hospital, if I'm not mistaken, also has the e-learning modules integrated into their system.
Yeah, they're MyPath. Yeah.
MyPath. You call it MyPath.
MyPath, yes. E-learning. Yeah. But e-learning does not benefit those who are hands-on learners. And that's what our premise is to get their hands on it, walk them through it, let them demonstrate it, get them comfortable.
Yeah. Absolutely. And again, I think that reiterates that we do have these simulation pads and training resources available. For those of you who play a leadership role in your institutions, we will, if you need them, if your educators need them, and if you need access to tools and resources, you can reach out. You can either post an inquiry through the chat, you can reply to the invites, or find us through social media or your local representative. If you're here in the United States, your EloQuest rep is a great resource and can work with you to get you what you need from support purposes. If you're outside the US, I know some of you are, you can work with your local distribution partner and we will help them help you. So
I'd love to travel.
we can always talk about that too.
Yeah, love that. Yeah. I'd like to piggyback on the resources that you just mentioned, Laura. So we, in addition to those pads, which, she said we can get out to you for those hands-on learning. Maybe you got one a few years ago and it's just fallen into disrepair. We can certainly replace that, so that there is that opportunity for whenever they need to do a little bit of hands-on practice. Maybe it's been a minute since a removal, so they want to practice, get the dexterity down right on with their fingers, with their hands. That's available as well. We do have, if you want to add one more thing to, your bouquet of your badge card, right? We do have a little learning card that is available for that as well. And if this is the first time you've heard, oh my gosh, there is an e-learning module. Yes, there absolutely is an e-learning module. It appears to be something that works with a variety of different systems or different platforms. So Laura's got the little badge card, which is a nice referral or reference, I should say, for you, for your team, for those maybe champions on the individual units that want to take on that task or being the resource for kind of on-demand learning. That's a nice reminder. But yes, those files that are very easy to upload into your systems or your facilities, a learning management system. We, again, reach out to us. We'd be happy to give you a link to upload those, and it does allow you to incorporate those right into your, standard nursing competency, which is when's a better time to get them, reminded of the basics of SecurAcath, primarily care maintenance and removal, than during their annual competency go around. So those things are available as well. And if you do have a more specific need for something, chances are we have a resource that meets that need. So feel free to reach out.
I'm going to ask Cheri another question, and then I'm going to use some props. What do you do for patient education, Cheri?
So it's a lot of real-time education. So we do talk about the SecurAcath. We refer it to like a seatbelt, because that's what kids can identify with. So it's a seatbelt, and it doesn't come off until we take the line out. So it's just the sticker that we have to take off and clean. When our patients go home, we do tell the families that the SecurAcath again stays in place. It doesn't come off until the line is ready to come out. We do talk about dressing change, that it's still an aseptic, very clean, using good hand washing when they're accessing their line. The SecurAcath, some home cares can remove it. We have done a lot of education with our home care. That is one of the barriers that we identified pretty early after implementing the use of SecurAcath. I had reached out to all our home care agencies asking for a representative in order to be able to provide them the education and sent them the information on the e-learning from SecurAcath. One of my teammates they had a lot of staff turnover. So one of my teammates last month did go and do in-servicing on the a lot of dressing change things. Again, it was pediatric focused because they were uncomfortable with pediatrics. We have intermittently had some home care nurses that have removed our SecurAcath weren't all that comfortable. So thank God for FaceTime. So, and we FaceTimed a couple of them during that removal process, where they felt much better. Afterwards, were they nervous? Absolutely. But again, it is that repetition to get that comfort level in removing it. We've also, again, like I said, we've had a couple physicians in the outpatient areas go to the site and initiate the removal on their own. And their response was, oh, I took it out and it wasn't that bad. So but the home care thing was one of our biggest barriers to overcome.
And I would say too, we have some patient education resources. Again, it varies from hospital to hospital how they want to utilize these. I can post in the chat a link to our patient guides. They are available in several languages on our website. They can be downloaded and printed on demand, or if somebody wants to pre-order them printed in English, we do sell these to our customers who order. So again, we sell them at cost, printing costs. Some hospitals have printing facilities available to them. Some people just keep it in a digital format and provide it to the patient, and their social worker or transition care teams print out a bundle, and this is part of that bundle, but it goes through what SecurAcath is and provides any care providers information and a QR code to our videos on demand. We also have our app online, and this is the QR code to the app on App Store and Google Play, which also is a great resource with quick, easy to use short videos. Those are the same videos that are available on our website, but the videos are there. And then for our US North American customers, you can tap that little phone icon and that gets you right to our 24/7 hotline for any assistance that you need. And the reason we did that is because, again, we recognize that learning curve out into the community, that routine use in the community is very sporadic. It's even more sporadic than in a hospital setting. And so we want to make sure that we have available resources, easy to access tools, and again, have those available as in many different formats. So again, on our website, many of the same videos that are on the app are available, and those printed tools are ways to get those tools available to others. In the future, we'll have little badge cards that are about the size of the business card for patients that'll have the same QR codes available to them, and or a wristband option, which is like a little tie-back wristband, and it says SecurAcath with a QR code on it. Again, we're trying to diversify ways that the information can travel with the patient, because the patient carries the device. But these are tools and resources that our EllaQuest partners and us have developed together, and we're hoping to make them more widely available for everyone who may need them. Again, quick short references. On the clinical care side, we have these badge cards, we have training folders. The folders also have printables, and the printables are also available on our website. So all of those are free to download and access at any time. And the links were posted in the chat. We'll post them again. I posted the patient guide link, but I will post also the resource videos and materials links again. Of all of those tools, Cheri, which ones have you used the most?
We have recommended actually the app. Most of our families have phones, so we have recommended the app, and that was well received. Whether they have used it much once they're discharged, I can't honestly answer that question, but we do offer that information.
And I know a couple hospitals just have one of these like kind of laminated on their cart, and they talk the patient through it, keep it, and then they have the patient scan the app. And then the patient has that app on their device, or their care providers, the parent would have it on their device, and they can share that app with others. So
we've also recommended our home care agencies actually download the app so that they have it with them.
Yeah, that's fantastic. We would like to see that more consistently done too. We are encouraging hospitals that adopt to push it out through their hospital-based devices, and have hyperlinks available for quick reference through their different communication tools. But we do know that we're one of many things in the hospital environment, so it can get lost like a needle in the haystack. but again, reinforce things that we think we've said or shared in the past. I think Matt indicated this, sometimes they get worn out. It's okay to ask for more. We want to help you have what you need to succeed at sharing information and training support for your teams. I know there's a couple folks that have joined. I want to reiterate, this is an open forum. We're here to answer your questions, but we're filling dead air space by talking. If you've got a question and want to unmute, feel free to jump in and interrupt us at any time. Also, you can, if you're not comfortable jumping in verbally or unmuting, you can just post your question or inquiry into the chat, and we'll be happy to work with you to get you the answer for the group. We're here for another 26 minutes. Am I correct, Matt?
That's correct. And I've just let a few new people in. So welcome. If you're just joining us, this is an open forum. We are here. Cheri is here to answer your clinical questions, good, bad, and indifferent. There are no dumb or silly questions here. This is an educational opportunity, whether you're just now learning about SecurAcath, or you're about to have that as one of your responsibilities, or you're still learning more, or just never had the opportunity to ask a question of a vascular access specialist before. So please feel free to unmute, speak up. Love to field your question, love to address it.
Cheri, while we're waiting for questions, can you show us again? I think one of the things we talked about earlier, but I'd love to mention is concern after a dressing change is done that the patient has pain. So sudden onset of pain within, an hour or so of the dressing change. What would you do to troubleshoot that scenario?
The first thing I would do is just do another dressing. I would come and assess to look to see where my SecurAcath is sitting, making sure that it's not cockeyed to the side, make sure, or, that it's not twisted here, or it's not cockeyed on either side. To make sure that hasn't happened, I would take the dressing down, and actually take the biopatch off, look at my site to make sure that my feet are not poking, so that we have a bad angle. And then I would redress it using my float and set technique over the SecurAcath. And then I would offer either a warm pack or a cold pack, depending on what the patient would prefer, to make sure that it's just superficial. If the patient continues to have pain, I would have the providers order an ultrasound to make sure that there's no thrombus formation along that PICC line.
And so is the pain associated with SecurAcath generally different than the pain associated with those types of symptoms?
Yes, the pain, if it's associated with the SecurAcath and after a dressing change, it usually has to do with the position of the SecurAcath or the tightness of the dressing. Most of our patients will complain that their arm aches if it's associated more with a thrombus formation.
So there's a sharp, very localized pain.
Localized burning, ache, burning pain is what they've described, that it burns and hurts, as opposed to an ache. And usually that ache, the definition of an ache, is more associated with our kids with a thrombus formation.
Okay, great. And could you use ultrasound to assess the SecurAcath also?
We could. We haven't needed to do that. But yes, we could use the ultrasound to assess exactly where those feet are laying, whether it's more in the dermis or if it's in the subcutaneous tissue. We have a lot of high-risk patients. So when we're looking at our cystic fibrosis and our HEMOC patients, those are the kids that we are most worried about with thrombus formation. So we take any complaint of discomfort to heart and usually go that extra mile and getting ultrasounds in those patients.
Right. Are there any audience questions? We're looking to make sure we're covering your topics. We can keep probing.
Maybe you have an anecdote you want to share. Maybe you want to talk about your first experience with SecurAcath, or a challenge you might have experienced. we'd love to hear those questions as well.
Maybe you want to celebrate a success story.
I would love to hear other people's experiences. Like I said, I'm spoiled. I'm also in one institution, and I have not yet visited other hospitals that have used SecurAcath outside of Galliceno Children. So I would really love to hear somebody else's experiences and any challenges that you had when you are orienting staff to the use of them, because I could use, maybe I could use some of your tricks of the trade. One of the things I have learned over the years is there's always something to learn. So I'd really like to hear from somebody on your experience.
You participated in both of the workshops at AVA just a few weeks back, didn't you?
Yes. That was one of, again, I've gone to many national meetings and have come home with a head full of, okay, I want to do this next or this, and just networking with people across the country. And the progression of vascular access just amazes me. And I get frustrated at times because New York State doesn't allow us to do some of the things, wonderful things that other people are doing. But I participated in the beginner PICC insertion class and met some amazing clinicians just starting their career or just within the first couple of years of their career in vascular access, and talking about securement and device navigation and tip confirmation. There's so much to learn and share.
Yeah, I remember you telling me that beforehand that you're going to teach at one, but you're going to be a student at one, and I think that's a great way to approach those meetings, is just to always be open to learning. So well,
just here, and hearing the successes that other people are having, whether it's decreasing their PIV rates or decreasing their CLABSIs or introducing some new technology. And I think SecurAcath has such a place in our specialty that many people don't even know about it. And the benefits. So for us all to be able to share our successes, and our challenges, the barriers that we've encountered, are to help somebody else learn from that and to be able to introduce us into their institution to improve quality outcomes. Because bottom line, this is for the patients. It's not for us. That's the bottom line.
You just said that it has such a significant impact in reducing those harms. Can you demonstrate for us specifically why you see that in your own practice in terms of preventing infection?
Again,
how do you see that? Like, what is the measure of that? Not just in your CLABSI rate as a statistic, but in the physical risk of an infection using your demonstration pad for the visual learners.
I mean, the biggest thing is that pistoning, like Matt's video, the pistoning in and out. I can't tell you when I was teaching staff on how to change a dressing using a stat lock. I'm going to just say the word. And we all, with the adhesive securement device, we all have a tendency to pull things closer to us as we're trying to do something. So there was that natural motion where they were actually withdrawing that catheter 1 to 2 centimeters, realizing what they did, and then go to attempt to shove it back in. And it's like, oh my God, please don't, and understanding that once it's exposed, it's dirty, and then to go, we've all pulled a line out. Believe me, I've pulled the line out in the wrong patient. But we've all done it, but it's not panicking. It's knowing what to do afterwards. We don't have that fear anymore. We've taken that fear away. So our dressings are being changed sooner, as opposed to being reinforced 3 or 4 times until you had an extra staff person ready or an extra 2 staff people available to help change a dressing. It's in the middle of the night when you only have 3 staff on and there's 14 patients on the floor, and you've got one kid who's not doing well. You have another kid who's puking and needs meds, and yet you have this dressing that's flapping in the wind and the adhesive coming off because the kid's febrile and sweating. You know, so when you look at the big picture, it's made an impact. It's made a true impact in our patient outcome, but it's also our staff satisfaction. You know, I think we forget about that sometimes, is trying to find something to help not just the patient, but also make our staff feel better about what they're doing, feel efficient, feel less stressed because they're being pulled in 10 different directions all at once.
Yeah, there is a little bit of void of empowerment feeling, right? So this is certainly something that can, and again, I'm going to reuse your words, make them feel more comfortable, make them more confident, more compliant with the steps that they know are necessary. Sometimes though, the risk and the pull from some of their other responsibilities is just too great. And oftentimes that those steps are not done correctly or done too quickly. And so this does provide some efficiency. You know, I can talk about the benefits of SecurAcath all day long, but as somebody who practiced at the bedside, just the peace of mind that it gives, that I can go in there and I can do a really good scrub around this patient's line without dislodging it. And I also know, as my acumen has grown, that when we're reducing that pistoning, we're reducing the body's natural response to set off that clotting cascade, which I'm convinced that clinically is going to lead to catheters failing faster, right? Because what's the body going to attack when it's feeling that, that pistoning, that movement? It's going to try and form a clot there. So what I'd like to do, and I think you were setting me up there, Cheri, is I'd just like to show the video again for the folks that have just kind of jumped on, because pistoning, and if you read Mickey's article in IV Quarterly, I believe, it's not part of the bigger vernacular. I think a lot of us know what pistoning is, but sometimes it's hard to describe it, and maybe even harder to connect it to what is the impact of this to the risk of infection and other complications. So I'm going to show that video again, and for those of you that again are visual and would appreciate that. So let me share my screen. I'm going to do the right steps here.
Yep, now I do.
There we go.
Yeah, so you got to remove the adhesive first, right? It needs to be done every dressing change, and then you got to clean it.
So the thing to recognize here too, Matt, is this is an experienced clinician changing a dressing with this amount of pistoning. And we forget about that brand new nurse.
So who's back doing it? Yeah.
Who's going to be actually withdrawing that line probably a centimeter and then pushing it back in, not realizing what is happening.
Or the impact.
And I know from experience, nurse, we're talking about you leave there feeling like you've done shortcuts if you're not doing a good job.
Yeah. I'm going to ask too, Cheri, on that, you mentioned earlier in the first part of the session, for those that may not have been on then, but have joined us since, different ways that you care for the dressings, take care of or prevent the strategies you employ to prevent, skin injury or skin concerns. Can you share with us your thought processes, why you might put something underneath or orient the SecurAcath a particular way, and when you do something, when you don't do something, why it's necessary, what are the real causes of skin injury? Not
So-
from SecurAcath, but generally speaking.
So generally speaking, it depends on the patient. So, you look at your patient population. If you have a very hectic kid, that's fluid overloaded, leaking, interstitially, when you look at our cardiac care kids, we see that a lot post-op, that we want to make sure that we don't cause any type of pressure injury. And that is one of the nicest things about the SecurAcath. But if we are concerned, we will take a little square of Aquacel AG. So it has silver, so it can stay under the dressing for the entire week, and place it under the SecurAcath, mostly to be able to help keep that angle of the SecurAcath so that the teeth stay embedded into the subcutaneous tissue. Because we know with the swelling, and then once they get rid of the swelling, so you have a lot of fluid shifts. So we want to make sure that we don't risk any type of skin injury at that point. Dressing changes, we still want to make sure that we are lifting like a hinge to make sure that we do not have any type of skin injury underneath if we don't have anything padding. Okay, so very important with that. So it all depends on our patient. We want to make sure that we have enough surface area to adequately maintain that dressing and the angles of the SecurAcath. So making sure that we have a nice little loop to prevent any cracking or injury, fracture or kinking of our catheters. That's especially important in our 2.6s.
Right.
Yeah, so it's, for the majority, we are all seasoned clinicians who've been doing this for quite a while. And our knowledge and our experience, we're passing down to our younger staff. So these are all the different things that we've learned over the years, and usually from some adverse event. So we might have had a little pressure injury under something. You can get pressure injuries still under an adhesive remover or adhesive securement device, depending on where it is and the condition of your patient. You look at adhesive skin injury. That's a big problem in our neonatal patients and in our elderly. So the using of adhesive removers for removing of dressings is very important. And I think sometimes we forget about that. Same thing with skin preps, putting that layer of protectant on that skin to protect it from the adhesive. There's a lot of tools in our toolbox that we need to be able to pulling out of our back pockets.
And I think it's important you mentioned, skin adhesive removers. There's the mastic to hold the dressings down. When we're applying the disinfection, the skin protectant, the gum mastic, and then using an adhesive remover, through each of these interactions with the skin, we need to dry the solution appropriately, follow the instructions for use, whatever combination of products you're using. What I often see related to skin irritation or skin injury, it's reported as an allergy, and that's incorrect most of the time. It's more of a reaction than an allergy. And we've created a chemical reaction because we've introduced multiple chemicals, and then we've close them in under a transparent dressing. So we've created this sort of closed environment to purposely protect the insertion site, but we've created a negative environment for our skin. So that's my observation. And I feel often that we communicate that to the patient. The clinical we tell the patient, oh, you're having a skin allergy to the adhesive, or you're having a skin allergy to this. And we don't know because we don't have allergy testing done. And instead, we're potentially jeopardizing the risk of this patient getting an infection because we're abating the standard of care because of that fear. And then they carry that fear with them for future medical care. And that's a bigger problem that we are creating. So I think with SecurAcath, we eliminate some of those interactions because they're happening because of rushing the dressing change because we don't want to lose our line. And with the SecurAcath, you can hold the line up. It's not going to move through that dressing change, and you give adequate time for that skin to dry between each of the steps that you need to take based on your hospital's protocol.
Yeah, and most of the skin injuries happen with the first dressing change.
Yeah.
Because somebody does not use the adhesive remover. And so you end up with that red patch where the dressing was, and then you're inducing injury and risk with the chlorhexidine scrub that they don't allow to dry 100%, and then put either the Cavalon, which seals the chlorhexidine underneath onto the skin, and then put their dressing on. And then it's just that perpetual wheel.
Yep. Now, I have your demo pad pinned to the screen. For those who might have jumped on late, can you give us another demonstration of the optimal removal strategies?
Absolutely.
No, we kind of started with, I figured it'd be good to kind of circle wagons all the way around.
Mhm.
Yep, absolutely. So 2 ways to remove your SecurAcath. The one that we use the majority of the time is to pop off our top and then remove our catheter completely. For this demonstration, I'm just going to put it up here out of the way. All right, you're going to actually put tension and hold just above your site. Lift up your SecurAcath and fold, and make sure your index finger is right over the blue, and then you're going to pull upwards with a wrist motion with purpose. The other way to remove it is to actually remove your catheter again, but take a pair of scissors and cut along the indentation of the blue. Once you do that, you still turn and then pop it out each side individually. We don't use scissors. Number one, if you have a pediatric patient, a toddler, they're not going to hold still. But even in the elderly, if you have somebody who has dementia or has delirium, I'm not going to go anywhere near those patients with scissors. I was trained in the 80s, and it was ingrained in us that you never take a pair of scissors near a central line. So we do not use that method. We again, I'll demonstrate again. We remove our catheter, lift up our SecurAcath, fold, and pop out.
And that angle, that 90-degree angle, right? We want to make that as easy to come out of the subcutaneous tissue and through the dermis as possible, right? So
yeah,
another common tool, I don't even know what the right word is, but right, we want that blue part facing the sky, right? We want it facing up, so we're not on an angle removing it where it's a 90-degree angle, so we know we come straight up and out with intention.
And then it pops right out.
Yeah, and I always say keep that blue to the sky or blue parallel to the skin. If we're keeping the blue parallel, then the toes are pointing into the insertion site, which gets you that 90-degree angle. I think too that 3-finger grip is really critical, because if you have your pointer finger on the blue, it is unnatural to bend your wrist to turn it and hook the feet underneath the device. So I think it's important when you're doing that to not pinch the wings with 2 fingers. So Cheri, show the wrong way. Often I see early removers or removers that are not frequent users, they pinch the wings with 2 fingers, and then they're like using their thumb and pointer.
Then they tried it.
And then they turn it so that it's like blue is perpendicular to the site, and that twisting motion or that cocking of the toes underneath the skin is what they're hooking, and then they're like, it's stuck, and it's not stuck at all. It's just a bad angle, and getting that angle correct, it makes that removal so much better for everybody.
Yeah. So
It's
I'm
not
trying to move my fingers so you could see and pop.
Yeah. Better for the patient, better for the provider. You know, if they're struggling and they feel like the skin is creating that tension, that's really uncomfortable for the patient, right? So holding counter traction and getting those corrected angles is really, really important.
And it took a few to get that dexterity piece.
And that's where the pads should come in handy, practicing getting the mechanics correct. The textures, the feel, the resistance will be different on the pad than it is in real life, but they're available to help people with the mechanics. So if we're not seeing correct mechanics as educators, we have to correct it, like call it out, show them why it's not right and what can go wrong so that they're thinking about it. I always find that the best learning happens when you talk about why. If you show things and correct things, but you explain why it's not correct the one way. My daughter is she's 11 and she's always like, no, mom. And I'm like, why do you think that's right? And let me show you why I think I'm right. Cheri, any final thoughts for our audience?
Don't be afraid of it. It works phenomenally. Be patient with yourself, especially with the learning curve. And you will be doing the right thing for your patient.
Thank you, Cheri. Thank you so much. I would add, reach out to your EllaQuest representative. You can send a message, reply to the email invitation. You can find us online. Hopefully you already know who your EllaQuest representative is. We're here to support you, whether you're thinking about evaluating it or you need some help a while after having implemented it. We're here to support you no matter which phase you are, because at the end of the day, as Cheri has reminded us so many times, there's so much for the patient to benefit, as well as the nursing by way of just improving efficiency and workflow. So we stand by to support you any way that we can. And with that being said, just want to thank you all for joining us today, and stay tuned for the next training opportunity.